Today's topic is important because regardless of your personal view of dietary supplements, herbs, botanicals, and other complementary therapies, this is an area we all have to be fluent in because the last figures I saw were that at least 80% of Americans use dietary supplements and 80% view the dietary supplement industry as trustworthy. It's a $70 billion industry now and projected to be $270 billion in 5 years. Year over year, more and more people are taking dietary supplements. On the NIH Office of Dietary Supplements, there are over 100,000 products. And for some, like melatonin, for example, there are over 500 different products and formulations. So it's daunting for clinicians and patients to keep track. It would appear from national surveys as well that supplement users are not taking these products as magic bullets, but as part of a constellation of healthy habits to support wellness. And I think that's key for what we're trying to do here at Atria and for how receptive and compliant our patients will be with recommendations that are intended to optimize their biology and their health. Indeed, consistently, the top reason US adults or adults in the US take dietary supplements is for overall health and wellness benefits and nutritional insurance, if you will. On the other hand, critics point out that dietary supplements are regulated as foods and not as drugs. They're not approved for effectiveness. They're not approved for safety. There are no mandatory standards for ingredient combinations or dosages. And systematic reviews in the literature indicate that there is a little to no evidence to support the use of many of the dietary supplements and botanicals out there that are being used. In addition to that, the NIH Office on Dietary Supplements cautions about toxicity, the increased risk of certain diseases like vitamin B6 and neuropathy, for example, and they caution also regarding the interactions of some of these with drugs that patients are taking, like antioxidants and chemotherapy. So it's a huge, huge topic. That's impossible to cover in one presentation, but we're fortunate to have Dr. Bauer here today with us to get us started. Dr. Bauer, Brent Bauer, is a professor of medicine and the founder of the Integrative Medicine program at Mayo Clinic. He's also the founder and former medical director of Rejuvenate, the first spa at Mayo Clinic. He's the medical editor of the Mayo Clinic Guide to Integrative Medicine, and he's the editor of the Science of Integrative Medicine video series. He's also the former medical director of the Well Living Lab at the Mayo Clinic Center for Innovation. His research and his work is at the forefront of the emerging field of integrative medicine, which combines the best of conventional medicine with the best of evidence-based complementary therapies. We're very lucky to have Dr. Bauer as a fellow of our Atria Academy of Science and Medicine, and I was lucky to have Brent as my senior resident when I began as an intern at Mayo Clinic back in 1990, a time that probably Brent doesn't even remember. So Dr. Bauer, take it away.
David, thank you very much. Everybody, thanks for taking the time. David, your introduction probably covered the key points. We could just move to the question and answer if you'd like, but maybe we'll go through a few slides and try and put some context around these things. And I think that's going to be really the goal. How do we get context? How do we have a practical approach? And the way I've tried to do that is I'm going to start with a little history. Where did we come from? Where are we going? Some of the terminology. What is integrative medicine? Some of you have reached out to me and asked, what is integrative medicine? Does that mean we're going to be wearing fringe jackets and smoking natural products? The answer, of course, is no. We're going to look at some of the data, and then we're going to try and put that in a framework that we can use to give evidence-based information to our patients and to ourselves, so that our patients can make informed decisions and hopefully get the benefits, avoid the risks, and hopefully that makes sense. Now, I started out after David asked me to give this talk, I went back, I better know the mission. So I went back and looked at the mission. I said, that's a great mission. I love it. But then I underlined the top part here where it says the greatest scientific and clinical minds. And I thought, well, gee, I've heard some fantastic talks over the last few months. A lot of these speakers have been running huge centers, big NIH grants, lots of grants, awards, prizes. And I thought, well, I don't really fit into that too well. My last major prize was in 1973 when I won an essay contest for what Christmas means to me. So I'm not in the same category as a lot of our previous speakers. And what I'm trying to get you to think about here is if the previous speakers put the bar up here, what I'd like you to do today is let's lower the bar a little bit. And it may not be as detailed or deep as some of our previous colleagues, but can we maybe step back, look at the 30,000 view and come up with an approach that allows us to do this in a way that makes sense. So one of the things David asked me when he talked about this talk is, could I hit some of the top ones? Could I hit fish oil, quercetin? And I thought, well, that's a great place to start. I'll pick 10 or 20, and I'll give you the absolute facts. And from that point, we'll go forward and you'll all know these things. We'll all have a happy time. And of course, what we do then is go back and do a deep dive. We know fish oil, at least epidemiologically, will reduce the risk of cardiovascular disease when it's consumed as part of the diet. It also reduces many risk factors. So it's plausible that if we took it as a supplement, we'd see the same benefit. And some of the early trials seem to suggest that. If you remember the GISI trial, looking at a standardized form of 300 milligrams of EPA, 600 milligrams of DHA, in a very large trial, 11,000 participants. And right away, that's an important point. As we look at most dietary supplement studies, we will not see ends of that magnitude. Many of the studies, because they're not generally funded by large pharmaceutical companies, because NIH money is fairly sparse in this arena, oftentimes we'll have to rely on participants of maybe 100, 200, 500. So already we know there's going to be some challenges in this arena. But in this particular trial, the endpoints were very clear: sudden death, total mortality, cardiovascular mortality. The graphs are pretty impressive. If you just look in the upper left, the total mortality, by 90 days, it was already separating at a statistically significant level, making us think there's probably some antiarrhythmic effect there. All these numbers look great. We probably could stop there and say the answers are in. And yet really the next 6 major trials that were done, some looking at the same question: does omega-3 fatty acid supplementation improve mortality after MI? What about just patients who have high risk factors? What about patients with high sugar levels? Supplementing them should show the same benefits. And yet in these well-done trials, pretty much no benefit, or at least neutral. And so now we're kind of stuck with this question of, well, how do we put this together? And if I'm going to sit and go through 10 or 20 different supplements, and they all have this kind of hard to pin down or get exact, we're going to be in trouble. And I thought, well, maybe we'll get some help. There's a recent meta-analysis just published back in February, so very recently, and a very nice trial. And again, I like forest plots because I think if I see a forest plot, I'm seeing believable data. MACE at the top is major adverse cardiac events. You can kind of see anything to the left of the null line would favor fish oil. And so if we look at MACE, CV death, or MI, we're seeing pretty significant effects there. So now we have the opposite conclusion of the last 6 studies. And that reminds me of the old quote that the devil can quote scripture for his purposes, right? So we could kind of pick a different meta-analysis. We could take different questions here, and then we could go another level. Are we talking about fish oil? Are we talking about a purified DHA or EPA product? Are we talking about the right ratios? Some of the negative trials have been criticized because they had participants take fish oil in the morning. And of course, it's not as well absorbed in a smaller meal or a less fatty meal. So now we have all of those questions that we somehow have to get our hands on. And then we're going to put that against the prism of precision medicine. Dr. Isaacson, Dr. Green, and some of the previous talks we've heard, highlighted the importance of precision medicine and the idea that we have to take in these other variables as well: genetics, environment, lifestyle. So now we start to think about this multi-tiered challenges, just even identifying what are we talking about when we talk about fish oil, and then how do we apply that to the individual in front of us? And this becomes very challenging. So then, of course, I started to think, well, when David asked me to give this talk, I wasn't quite 60, but I turned 60 between then and now. And I thought, well, that's got to be some wisdom. I can sit back and maybe be a little more thoughtful about this. And so rather than trying to run through, here's what you need to know on 20 different herbs, which may not be the ones that you need to know for your practice. They may have nothing to do with the types of patients you see. So I thought, well, let's try and do something that we can all agree. Here's the starting point. And when we do encounter a patient or ourselves using a supplement, how do we answer the question? Is that the right supplement for them? Is there a better alternative? What are the safety issues there? So here's my plan for today. I'm going to try and put this stuff in context. and especially my context. I'm not coming at this from the idea that what I do is give patients herbs. I'm going to come at it from the context of integrative medicine in general. The history is kind of interesting. I think that helps inform why there is this dichotomy. Some of us on the call are going to be very anti, some are going to be very pro. How do we get to this point? Why are patients so enthusiastic? And then what is the current usage? And I think that'll tell us why this is important. David alluded to that already. The regulatory status is a little challenging. And then are there risks and are there benefits? And of course, the answer is yes to both. And then very importantly, are there resources that any one of us can tap into and answer a question on the fly when we're dealing with a patient in the room with us? And then if we're successful, put all that together in a way that we can agree, yes, this is how we can answer those patients for our questions for our patients. Hopefully that sounds reasonable. I'll just keep going ahead and assume it is. So I said personal, and I'm also going to give you the national context for what I think dietary supplements have been doing. To those of you who have asked if I'm a weird person who grew up, with a fringe jacket and doing all those hippie type things, the answer is no. My training was very, I think, standard conservative. I went to Mayo Medical School. I did my residency at Mayo. I did a year of advanced general internal medicine fellowship at Mayo. And then in 1992, I went down to Mayo Clinic in Arizona and joined the staff. And so at that point, I thought, wow, I'm finally going to be a Mayo doctor. I'll probably see really complicated patients. They're going to want me to diagnose, pseudo hypoparathyroidism, Uzbekistan fever. And by gosh, I was ready to do it. And literally my very first patient, sweet little old lady, sitting there at the desk with a jar of echinacea. And her question to me was, Doc, what do you think of echinacea? Now, this is back in the early 90s. I didn't know what echinacea was. I had not been trained in this, but I was young. And I said, well, tell me about this because I don't know. And it was very interesting. Once patients found out that there was a physician who would at least hear their interest, and they would start bringing me magazine articles and sign me up for courses on Jin Shin Jitsu so I could learn some energy healing. But it became very apparent to me that our patients were doing a lot of things, not just supplements, but a lot of things that we didn't know about, some of which were actually very helpful. And that area, we'll talk about some of the things like mind-body practices, which we could probably expand the role for our patients if we knew about them. But I also saw patients being harmed, right? We saw some liver transplantation be required because of patients using the wrong herb or the wrong amount. So it became very clear to me that we had to have a more comprehensive approach so we can inform our patients. Well, that was my personal journey that got me here. Same thing I think was happening nationally, right? People were recognizing that more and more of us, US citizens, were doing something in this realm, not just herbs, but in the realm at that time, which was often called unconventional medicine, unorthodox medicine. But this is a nice study from David Eisenberg and colleagues at Harvard, a big telephone survey. And they used the definition of things that weren't typically taught in medical schools, not typically available at hospitals. And they asked specifically about chiropractic, massage, acupuncture, meditation, herbs. And what that study said is, yeah, about 34% of Americans were using something in this unconventional realm. So that kind of put it on the map. I think it brought attention to this area that we couldn't just assume as clinicians, researchers, that this was a fringe phenomenon. It was leftover hippies from the 60s. And once they passed on, we wouldn't have to worry about it. It was actually a pretty significant part of our population. And then they helped us again. They came back about 5 years later, same idea, little larger trial. And by this time now, the usage was up to 42%. You can see the terminology keeps evolving back then. Now they're calling it alternative therapies. We also saw that certain groups had even higher usage. So the 35 to 49 year age group was up to about 50%. We also knew from that time, from this study and others, that patients often didn't disclose what they were doing to their primary care team for a variety of reasons. We'll talk about that. And then I think where really the attention got fairly high, they identified we were spending about $27 billion each year in the United States on these different therapies. And then the visits, you'll see in 1997, the visits had increased to alternative providers up to about 660 million, which actually dwarfed the number of visits to primary care providers. So now we had a recognition, I think, that this is something we have to know about. It's going to be part of our care going forward. We have to be able to make informed decisions. And that was my intention coming back from Arizona, came back to Rochester, and I proposed we should have a program because our patients were going to be using this stuff. We had to have a better idea. And yet there was pushback to that idea because people said, well, wait a minute, at Mayo Clinic, we take care of complicated patients. They're not going to be messing around with this kind of stuff, so don't worry about it. So we did a number of studies, and this is one where we showed that actually, compared to the national norms, our patients were even more likely to be using something in this realm, whether it was massage, acupuncture, Tai Chi, supplements. And so that became very obvious that, and if you think in retrospect, it's very obvious, I think, why our patients are oftentimes very complex. They oftentimes have problems that are not immediately curable. And so it's not unlikely that they would be looking for what else is out there that might help me. So again, this kind of put it on the radar screen, I think institutionally, at least for Mayo, that we needed to come up, excuse me, with a good program. So this is when we'd established what we called the DOM, was the Department of Medicine Complementary and Alternative Medicine Program. This is back in 2000, using the terminology at that time, CAM. And the idea was, look, let's do research. Let's look at through the lens of education and practice and come up with a way so we as providers could talk to our patients and help them make informed decisions about all of these things. So what happened at Mayo, both inpatient, outpatient, we started to do a lot of research. And one of the early ones that I thought was kind of pivotal was when the cardiovascular surgeons reached out and said, look, we want to reduce the amount of pain patients have after open heart surgery. And we talked about a lot of things. We talked about some herbs, acupuncture, this and that, but they were intrigued with massage. So we did a trial that they helped us design, and the endpoints were such that if they were positive, they would, have action for them. And this was a particular trial where we had massage therapy provided on day 2 and day 4 after open heart surgery versus a quiet relaxation time. And although it was a pilot trial, reached statistical significance for reduction in pain, anxiety, and muscle tension, which wasn't quite enough for the surgeons to change behavior, but we replicated the study. That one was positive. And they went ahead and hired massage therapists as part of the routine aftercare for open heart surgery. And so this will be my theme going forward. Research is what's really going to drive our decisions, not an advocacy. I think you should do this, you should take that herb, but what is the research and how do we interpret it for the individual in front of us? So that's kind of how we got started. As the evidence grew, we shifted from CAM. We introduced the term integrative medicine, the idea we were bringing the best of both worlds together by 2006. And by 2014, we dropped the terminology complementary and just now identify it as an integrative medicine approach. And that looks very much like what happened at the national level. You may be familiar with the Office of Alternative Medicine. That was an Congress created office within the NIH. That quickly changed to the becoming a full NIH center, the National Center for Complementary and Alternative Medicine. And then by 2014, they also dropped the alternative and became the National Center for Complementary and Integrative Health. So they've been one of the main funders. There's also quite a bit through the NCI funding studies in these areas, which start to help us be able to make more informed decisions. So what is the definition of integrative medicine? I've been using it for a little while. I like the definition from the Academic Consortium for Integrative Medicine and Health. This is a group, about 75, 80 different medical schools, academic medical centers, mostly from North America, but also some international representation that meets on a yearly basis. Every other year has an international research congress, but has working groups on policy, education, practice, research. But their definition is one that I like and have kind of used in my practice. They identify integrative medicine as the practice of medicine that reaffirms the importance of the relationship between practitioner and patient. And right there, that's already telling us, it's not saying the physician and the patient or the nurse and the patient, it's opening the door that there may be other people and other providers, excuse me, that can be part of this as well. Focuses on the whole person. I don't think that's unique to integrative medicine, but many of us find the pressure of practice sometimes makes that hard to maintain. So being reminded that is good. Then here's the critical part. Everything we're talking about in integrative medicine has to be informed by evidence. So there's many things we offer here at Mayo. We do offer massage, acupuncture, meditation, animal-assisted therapy. But for example, we don't offer homeopathy. It doesn't mean homeopathy can't work or doesn't work for some patients, but the level of evidence has not risen to the point where we would incorporate that. So always standing with the evidence and making sure we don't get ahead of that. And then the idea is, well, let's use all these appropriate evidence-based therapeutic options and practitioners. And really what I look at this is it's an expansion of my toolkit. If I wear my conventional medical hat and I'm in the hospital, I have a patient with pain, I have some drugs, probably shouldn't use opioids, I might get some physical therapy for them, but I kind of run out of options fairly quickly. But if I have an integrative medicine hat on, I can also look at them and see if they're interested in massage, acupuncture, a mind-body practitioner, a visit from a dog. So there's a lot more opportunities, again, as long as we build it this way. So again, trying to get the context of where do herbs fit into all of this. We've done a number of trials. I won't go through all of these, but again, this is how we've translated practice at Mayo Clinic. So what does that research look like when we talk about dietary supplements? I picked a few of them. These are not all, and I'm going to focus in the middle there. You'll see we've done several trials for patients with cancer. And you'll see two of them related to American ginseng for cancer. And the first study was fairly positive. We could show a significant reduction in fatigue at a certain dose of American ginseng. And the American ginseng was standardized in a certain way to make sure the ginsenosides were maintained throughout the different batches. And that was replicated again by another study a couple of years later, to the point where it became fairly obvious that many patients, not all, oftentimes benefited. And it was never then incorporated into the practice with the idea of if you have fatigue, the first thing you do is take American ginseng. It was incorporated in, first thing we're going to do is make sure we've optimized your nutrition. You've got a gentle graded exercise program. We've done all that and you still have fatigue. Now we have the opportunity to say, maybe in your individual case, if there's not a contraindication, we could try American ginseng. And so that is now routinely offered or at least discussed with many of our patients in our oncology setting. So as I start to go through all of our research, what has come back many times is where's the biggest bang for the buck? And it hasn't been with the dietary supplements. Many of those trials were either neutral or negative. They didn't reach the goals we were hoping for. And yet when we go back and think of some of the previous speakers who have identified what does it take to optimize health and wellness going forward, we hear about healthy eating, exercise. We've talked a little bit about the effects of stress and where mind-body might come in there, social connection, restorative sleep, and then either spirituality or passion or purpose, however you want to frame that. But these are the things that we've heard. And we also know whether we're looking at telomere lengthening or reducing the risk of cancer, reducing the risk of heart disease, reducing the risk of Alzheimer's, we want to have an active program here. And you could say, well, what does that have to do with integrative medicine? Well, in each of these domains, I think we have things that we can talk about that expand, again, the opportunities. So when I talk to patients about a healthy diet, we're usually focused on the Mediterranean diet, but we can quickly also incorporate ketogenic diet, intermittent fasting, and when appropriate, the role of dietary supplements. I see a lot of older folks, so a lot of them aren't going to be able to go out and do even a brisk walk, but we can start them out with seated Tai Chi and get the idea of motion and movement. Sorry about that. And kind of get the idea that there's some efficacy we can develop and then maybe graduate to other things. And then really mind-body certainly lives, I think, within integrative medicine, and we're finding tremendous benefits for our patients with meditation. We do a lot of work with the biofeedback assisted meditation devices and finding good stuff. Social support, again, not unique to integrative medicine, but there are some fun things we do. Group acupuncture here is one way of keeping costs down and making it more available, but there's also some interesting things that happen with the group dynamics when you have similar patients together. Sleep, again, not the first thing I reach for, but when I'm seeing a patient and they haven't responded to good sleep hygiene, our best conventional efforts, do I look at things like guided imagery, melatonin, biofeedback on a case-by-case basis? Of course, the answer is yes. And then spirituality or that passion purpose idea is not, again, unique to integrative medicine, but it oftentimes transcends religious experiences. Some people say it's nature. And again, we've got a lot of work in the realm of biophilia. Are we as humans wired to be connected to nature? And we've got lots of studies saying we are. So then how do we incorporate that? What are the tools we make that happen? So in that context, hopefully you see a lot of what I would think of as integrative medicine is really a lot of the things we've talked about already, and I think have valued as where we're going to go to try and optimize health and wellness. But now we can expand our thinking a little bit, and that's going to include, excuse me, dietary supplements. Where do I see dietary supplements? This is what I often encourage my patients to do, because many of them come in with lots of supplements and they're convinced that's going to be the way they stay healthy. And then we have this conversation about these domains. And the idea is if you have $1 and you want to be as healthy as you can, let's put about 90, 95 cents of that dollar into those lifestyle things. Let's get the best exercise we can, buy the best whole foods we can, maybe buy a meditation app or something. It's going to leave us a nickel or a dime on the other side, where then supplements can do what I think they should do, supplement everything else. They are not the driver. They're not the main thing we do. EE would be everything else. So there's a lot of things our patients are interested in. And I think, as you'll see, there's a way to recognize that interest and use it to the advantage both of the patient and to encourage what we want to do. So that's sort of hopefully the context, at least where I'm coming from, where I think we should be heading. We'll be interested to see what your questions are. Second part I want to dive into a little bit is the history, because there's no question there is a difference between many physicians and many patients. And how do we get there? The history is part of that. Now, doctors should not be anti-herb. And why I say that is it wasn't that long ago that if you looked at our Materia Medica, and this is from 1845, this is one of the things my wife does not appreciate. I collect a lot of old medical equipment and books, so my basement is full. But then I get to show a picture like this, and I feel like it's all justified. But this is the Dispensatory of the United States of America. You can see Dr. Wood from the University of Pennsylvania, Dr. Bakke from the Jefferson Medical College. And what they've accumulated here is about 200, 300 different medical treatments that were available to physicians at the time. And I would say about 90% in this book all come back to herbs. So foxglove, of course, a source of digitalis, lavender, recognized for many uses. So it wasn't that long ago, and even to like about 1920, about a third of the pharmacopoeia in the United States still had a heavy reliance on herbs. And of course, we also should like herbs because a lot of the herbs, the natural products, have given us some of our common medications. So why would we have this kind of negative pullback when we hear about supplements? It seems like they're kind of in our history. And yet I think where a lot of that comes is from patent medicines. And so if you're familiar with the late 1800s, early 1900s, patent medicines were the rage. And there was a patent medicine for anything. And patent medicines basically meant you created a formula, didn't share what was in it, but you could get a patent for it, and then you sold it. And one of the ways you could do that was with trading cards. So this is a trading card for Mrs. Winslow's soothing syrup. You can see in the bottom, it's for children teething. It probably works because you see the baby eagerly reaching for it. And what they promised was it would produce a natural, quiet sleep. Anybody want to guess what the natural ingredients were? Yeah, it was opium and morphine in an alcohol base. So actually several babies actually died as a result of using Mrs. Winslow's soothing syrup. And there's many, many other cases where people were selling things that had lots of alcohol, opium, other agents, and so forth. So this was kind of a calamity in terms of what patients were spending their money on. So Samuel Adams, not the president, but or the patriot, Samuel Hopkins Adams was a reporter for Collier's. He did a very interesting, if you ever want some weekend reading, read The Great American Fraud. He did a series of articles where he really dove into what are Americans doing. And he figured out back then we were spending about $75 million per year buying patent medicines. And what that really did is it kind of raised the recognition that things were being sold with a lot of stuff in it that wasn't safe. And that led to the Senate passing the Pure Food and Drug Act. The House wasn't quite as interested and was kind of letting it sort of fade away. And then if you've read The Jungle by Upton Sinclair, with all of the horrible meat packing processes and the lack of sanitation, that got everybody excited, and that allowed the Pure Food and Drug Act to pass. So that was a step in the direction of saying, let's not sell things that aren't what's on the label to our patients. And yet it didn't really stop any of the patent medicine furor. Patients could still find lots of stuff advertised. You can see Rengo probably works because clearly that's an unretouched photo before and after. So I'm pretty sure it worked. And we kind of laugh at some of that. Well, I can't believe they did it in the 1900s, but here's more recently ones. Here's a fat blotter that allows you to eat all the foods you love and still lose weight. So again, now I think we start to see, well, there is a pretty rich history, and it's still kind of in the background today where some, let's say, less than scrupulous manufacturers are selling things with hype, with claims that aren't substantiated, oftentimes with products that aren't high quality. So I think we're justified when we say, yeah, there is some skepticism there, and probably deservedly so. So now that takes me to, okay, well, now we have some mythology that's grown up. And I think the myths are important if we're going to kind of find our own way as a group and individuals and how we handle dietary supplements. So myth number one, from a doctor perspective, I hear a lot of times, well, supplements have no evidence. You can't talk about them, throw them away. We're going to do something more important. Well, of course, that's not true. This is a clinicaltrials.gov search I did just a couple months ago on quercetin. So a very common, very popular supplement right now. And you can see there's over 104 registered studies on quercetin. And you can say, well, that's interesting. Studies don't mean much. Show me the data. And so we can go to PubMed, and I just did a search here on dietary supplement, limited to clinical trials, and you can see we have about 19,000 hits. Now, it doesn't mean every hit is a perfectly well done randomized placebo-controlled trial, but it starts to get to the idea there's a lot of data out there. And we can do a deeper dive if we do that same search, but limit it to cancer. Excuse me. You see about 1,400 manuscripts out there that we can turn to and at least start to get an idea of what is the benefit, what are the risks, and how do we use these appropriately. The second myth, or the thing I hear a lot of my colleagues say, well, you're taking supplements, it's just making expensive urine, don't waste it, waste your money. But in fact, that's not true, because if you've ever seen hypersegmented neutrophils and you see a patient with neurologic damage and you don't give them B12, we're not helping them, right? So B12 deficiency is an obvious example where it's not expensive urine. Giving them a dietary supplement, in this case, vitamin B12, can be life-saving and may prevent neurologic problems from becoming permanent. So that myth, I think we can debunk. Now we go to the other side. Well, what about these patients? As David alluded to earlier, we've seen this steady rise over the years, and some studies now suggest about 80% of US adults are using some type of dietary supplement. So what are the mythologies on that side? The one I hear from a lot of patients is, I'm not worried about my supplements. They're natural, they're safe, so don't bother me with them. And my usual rejoinder to that is, well, hemlock's pretty natural, and it really wasn't very good for Socrates, was it? So the idea that natural correlates with safety is readily debunked. We can talk about tobacco is natural, strychnine's natural. So a lot of ways to kind of help them reframe their thinking and be a little more careful. The other myth, and I think this is a tough one, if a little's good, a lot's better. And so we'll see a lot of patients taking very high amounts of something with the idea that I heard it on the news, I need X, and I'm going to take a lot of X. And an unfortunate example is this is page 1 of 3 of the dietary supplements this patient was referred to me. And her question was, I'm doing what I can for my health, but I think I'm missing something. What's the next 5 or 10 I should add here? So again, this is a very common myth in our population, right? Patients think that this is where health lies. If I get the right combination of supplements, then you turn to them, but they're still smoking, drinking, not exercising. And so there's a real opportunity when we see this type of usage. And of course, we can go back to Osler, who recognized that we seem to be wired to want to take medications. And part of our job, I think, is to make sure we're not part of that. Let's take more and more, unless there's an evidence-based targeted reason. So that's kind of the mythologies. Again, you could come back and say, well, that's interesting, but really, is it that big a deal? And I think the answer is yes. If we go back to some of the large NIH trials done in the 2000s, this is one from 2012, wherever they found patients were using something in the integrative or complementary realm, the number one thing in all those studies is always natural products, which again, I think reflects the fact that patients are very interested in trying to take something, especially if it's perceived as natural. And so therefore it is part of our healthcare if you think about what our patients are doing routinely. And I think it's increasing. This is a study from 2014 suggesting about 68% of adults were using something in this realm, a little higher if you're older, and maybe a little preponderance female over male. And again, we can argue back and forth because some of these studies include vitamins, some don't. But the point is, however you slice and dice it, we're seeing a pretty steady rise and a pretty persistent interest. And so if 80% of our patients, let's say that's generous, let's say it's only 60%, it still reflects the fact that we, whether we're talking about our approach to patients coming to Atria, our approach to our patients in our own practices, or again, even to ourselves, we have to have a strategy of how to do that in an evidence-based way that we can apply to all the herbs and supplements we're going to see. Because even if we looked at the top 20 or 30 or 40, next week there's going to be something we haven't heard about, and it's going to be the number one seller. How do we respond? What do we do to do that? And when I threw this in, it's just very interesting to see how quickly we pivot in the United States. If you go back over the last 20 years, the number one seller in 2020 or 2019, or I'm sorry, 2010 is not the same number one seller in 2020. So patients do respond to what they read and hear. And of course, vitamin C, D, and zinc were touted as ways of preventing COVID. And so you can see a very dramatic rise. And yet how many of those patients actually sat down and discussed with their care team how much zinc is too much, when should I take it and do it? So again, opportunities for us to kind of be ahead of the curve because we know new things are coming down the pike. And David also alluded to this number of studies looking at patients who use dietary supplements and those who don't. And those who do generally have associated better health behaviors. They're less likely to smoke, more likely to get good sleep, more likely to have healthy weight. So this makes an interesting challenge because when we ask, well, what are dietary supplements doing? Are they helping patients? That may be a confound because maybe the supplements have a role. Maybe the supplements are just a co-traveler with the good healthy stuff they're doing. This is a study from Denmark looking at adults who use dietary supplements, and then they looked at the health index. A rise in health index is indicative of better health. So when they looked at a 1-point rise in health index, more likelihood of using dietary supplements by 19%. And then the reverse, metabolic risk being negative, the higher that went, the lower the dietary supplement use went. So again, there's a marker here, and I think this is also something we can use to our advantage as we try and help our patients optimize their health. All right, so I mentioned the regulatory challenge. Are things like curing pills out there and making wild claims? And the answer is yes. The regulatory environment has changed since the Pure Food and Drug Act. Another big one was 1994. You'll often hear it referred to as the SHEA. It's Dietary Supplement Health and Education Act. And again, David alluded to this. It makes this category of dietary supplements, which sort of do fit under the food category, but kind of separate. And what it really does is say, okay, we have these things. You can now market them with a dose. So prior to that, you weren't allowed to say, take 500 milligrams of saw palmetto. And now it's kind of giving a little more legitimacy. And to David's point, it specifically exempted these supplements from having to be tested for safety or efficacy. If they had been used for many years as part of a health-oriented approach, they were kind of grandfathered in. They did not have to go and do a lot of studies. So that actually kind of opened the market in some regards because now they could share dosage. It did restrict claims. So you're not allowed to sell your product and say, this is Dr. Bauer's saw palmetto. I'll help you pee less often at night and you'll have a smaller prostate. That would be a medical claim and I'd get in trouble with the FTC for sure. But I can say structure and function improvement. So things that are related to the structure, I could say, for example, my saw palmetto will help improve function of prostate, or it can improve overall prostate health. So it's a little disingenuous, and many of the less high quality, if you will, manufacturers skate very close to that. And many of the things on the internet are still blatantly advertised as a medical indication. And I think the FTC has primary oversight of that. And again, it's underfunded in terms of FTE to police that. So there are still a lot of bad actors out there, which does require us to take, I think, a preventative role with our patients. So what about the quality of these products? This is a study from 1998, but there's been many subsequent ones where they pulled some products off the shelves, evaluated them, and found, guess what, a lot of contaminants. So a lot of the herbal Viagra that was very popular 15 years ago actually was probably working pretty well because it had Viagra in it, right? So there's a question about quality. So not only can we limit what we say, but now we still can't tell for sure, are we getting good high quality products? And the next thing that helped us in that regard was good manufacturing practices. So good manufacturing practices were mandated. They were rolled out over a couple of years to allow smaller companies to catch up. But now companies that are manufacturing or selling in the United States do have to, or are required to, identify the compound, the strength, purity, and all the data on the label has to be matched with what's in the jar or the bottle. So that's a huge step forward. Excuse me. And again, many companies have stepped up and gone beyond this. Many companies are still lagging. And again, how do we identify that and find the good ones is something we will talk about shortly. Okay, so background, kind of where we're coming from, why it's important, some of the issues and challenges, why this is a unique environment. What should we do with this? If there's nothing but risks and no benefits, it's a short talk. We can stop there and just tell our patients no. If there's no risks and all benefits, then everybody should be on it. And of course, what we're going to try and do is come down the middle of the pike on that, because there clearly are risks. If you're familiar with St. John's wort, it actually has a pretty good track record for mild to moderate depression. So it works pretty well, but we also know it has a pretty good impact on the cytochrome P450, CYP3A4 subenzyme system, and intestinal P glycoprotein. So what that means is it can rev up metabolism of many drugs. And one of the side effects associated with St. John's wort has been babies. How do we get babies from St. John's wort? Well, one of the drugs that is expedited with metabolism, oral contraceptives. So women with effective oral contraceptives feel a little depressed, take St. John's wort, and the oral contraceptives are no longer effective. Seen similar things with cyclosporin. Patients who have heart transplants, cyclosporin is pretty important. Keep it at a therapeutic level. Felt a little depressed, added some St. John's wort, cyclosporin levels dropped, and at least 2 case reports of patients experiencing heart transplant rejection. So again, are there risks? Absolutely. Herb-drug interactions are something we want to be very careful about. And fortunately, there's some good reference material we can tap into to help us make sure we don't get into trouble with our patients doing that. And then another case report I think is interesting. It kind of goes back to that idea, if a little's good, a lot's got to be better. This was a case report on a gentleman drinking some green tea. And you're probably familiar with the recommendation, usually if you're on Coumadin or warfarin for your anticoagulation, they're generally recommended don't drink a lot of tea. It may have some vitamin K in it. Well, this was a story of a gentleman who had mechanical heart valve, so very important not to have the anticoagulation get too low, but that's what happened. And in retrospect, what they figured out is he's drinking about a gallon of green tea per day, which had enough vitamin K to reverse the warfarin. So again, recognizing these things, helping our patients make informed decisions, I think we can stay ahead of most of the herb-drug interactions. Some herbs just have some risks we have to think about in and of themselves, even if they're used appropriately. Here's some nice garlic. A lot of people mentioned the G herbs, garlic, ginger, ginkgo, ginseng. All of these have had at least an indication that they might have some antiplatelet activity. Garlic, for example, has been associated with postoperative bleeding. One gentleman who had a epidural hematoma of the spine when having some spine surgery, and they didn't stop the garlic ahead of time. So again, this isn't garlic is good, garlic is bad. It's how we use it, and are we informed? Is the patient informed? And then we can be successful and hopefully get benefits when they're there, but also avoid the harms. There's a lot of other risks that we can certainly talk about. The herb-drug interactions, though, I think are important, since more than half of us are taking a prescription medication. The herbs can have side effects of their own. But 3 other things that I think we have to keep in mind is that a lot of patients use supplements instead of getting conventional care. And sometimes that's not a big deal, but I've seen, unfortunately, a number of young ladies who've had early breast cancer who were fearful of chemotherapy, fearful of surgery, fearful of radiation, to the point where they tried just natural products and then come back 6 months later with a very different cancer and more limited options. So we want to make sure our patients are making informed decisions there. It used to be patients said, I'm going to use herbs because those prescription drugs are so expensive. And now many of the herbal supplements can be equally expensive, or at least nearly so. So we've got to be careful that we're not, our patients aren't incurring needless expenses if they're not getting the benefits. And then false hope. Unfortunately, if you go on the internet now and just put in cancer and herb, you're going to find lots of companies that are going to try and sell you things. They'll invite you down to Mexico and all kinds of places to do things that probably don't have much evidence, and certainly can raise hopes when that may not be an honest approach. So are there benefits? And I guess the answer, of course, is yes. I think we do this all the time in conventional medicine. For example, if we're starting somebody on metformin, oftentimes we'll start the B12 supplementation right away because we know that can be depleted. I don't think you would start methotrexate typically without starting folic acid. So when we use a dietary supplement to prevent depletion, that to me is obvious, and that's one of the benefits we don't want to miss. Obviously, we want to replete depletion, right? We see a lot of patients with vitamin D deficiency, and this is very common in the elderly, very common in patients with darker skin. It's hard to know who has it. And so I've been pretty routine checking vitamin D, certainly in my patients over 50, but I found vitamin D deficiency in a guy just this morning who was 42. And he had a total vitamin D of 10 nanograms per ml, way too low, and that probably contributed to a lot of his problems. So again, using a dietary supplement to replete a depletion, I don't think we can argue we've got to do that. Then we can maybe get a little more debate going in the question and answer session, but do we use supplements to meet an unmet need? So for example, I have lots of elderly patients, lots of them have joint pain. Of course, we try conventional things. We often have acetaminophen or some anti-inflammatories. What happens when they don't respond to that in physical therapy, but they still have joint pain? Do we use glucosamine? Absolutely. I always talk to my patients about the pros and cons, the likelihood of whether it helps a lot or little. It might take 3 or 4 months to see the full effect, but many patients come back and say, thank you, that's the thing that helped more than anything. And many patients come back and say, I got nothing out of it, and we try something else. So I think there's low reason to argue there. There may be a little more debate where we have some evidence. It's not strong enough yet that we would endorse necessarily, but we also have a problem that's not really responding to our best conventional efforts. And here I see a lot of patients struggle with sleep and pain. And here I often use the mixed cannabinoids, where oftentimes they can be extremely helpful, peripheral neuropathy, other chronic pain syndromes. And again, probably a third of the time, no benefit. But helping somebody avoid a narcotic or an opioid and getting some benefit, as long as we use it carefully, we watch for the herb-drug interactions, we track to make sure they're not responding in an idiosyncratic way where they might have liver function test abnormalities or so forth. So again, the idea that herbs are all just expensive urine, I think we have to keep that open mind. Risks, definitely. Benefits, yes. How do we come to that middle ground? So our goal, I think, as a healthcare team, whatever role we play, I think we should try and make it as easy to talk to patients as possible about their herbs. We teach our fellows and residents and medical students, when you're taking the history, you always ask about drugs. When you ask about drugs, just ask about dietary supplements. So it's not seen as a different category or something unique. You tell me the medications you're taking, what's the dose, what's it for, what are the herbs you're taking, what's it for, what dose, what's the manufacturer. So again, we can get that information. And if we do it in a non-judgmental fashion, patients are generally pretty happy to share that information. Now, when they share that information, we have to be able to answer their question, like, is this safe? Is it interacting with our other drugs? And so for that, I think we need a quick place to go and get a question answered. Now, some of the references or resources I alluded to earlier don't serve that purpose, right? PubMed is not an easy place to go and say, does a mixed cannabinoid have an interference with Eliquis? We're not going to find that very easily. Same thing at NIH is a great resource. There is some good herb information, maybe a little more geared towards patients, but again, not quite the level we're looking for. David alluded to the NIH, the Office of Dietary Supplements. Again, if you leave here today and say, I really want to go deeper, I want to understand the regulatory environment more and more, this is a good place to do that, but practically not so much. Always throw in Mayo Clinic. I always think we have some good stuff, but again, not the level we're looking for. And the academic consortium, all of these are great places. If something we've talked about today piques your interest and you want to go a little deeper, that's where I would go and say, okay, I'm going to sit back and gain knowledge, but I need something when I'm seeing the patient because I have to answer that at the bedside, so to speak. So I'm going to share 3 of these with you. These are all ones that either we have a site license for at Mayo Clinic or I have a personal subscription to. These are all ones we use in our practice on a daily basis. These are not necessarily the best. These are not the only ones. We have no financial connection with any of these resources. So I'm throwing them out as, here's what I use. Here's why I like these. Here's each one does a slightly different thing. And when I put them all together, I can usually answer any question that my patients are bringing to the table. So here's Natural Medicine's database. You can see on the left side, there's an interaction checker, an effectiveness checker. We can just start at the very top and do a search on anything we're looking at. Let's say the patient's on turmeric. If we do a search on turmeric, you see very quickly, you not only get the proprietary products, the commercial products, but at the very top, something called the professional monograph. And what those look like are very extensive reviews You can see again on the left side, warning, safety, adverse effects, drug interactions. So you can go from head to toe in a very short period of time and get a lot of information. But again, the way I often use these is the patients in front of me saying, what can help my insomnia, what can help my problem. They also have what they call a effectiveness checker. So I can put in a condition, in this case, insomnia, and you'll see then we get ratings: likely effective, possibly effective, insufficient evidence, likely not effective. And you can see right at the top, for delayed sleep phase syndrome, melatonin is likely effective. So now we can very quickly kind of separate things. You'll also see here that they've included acupressure as possibly effective. So they also do some ratings of other therapies besides supplements, but primarily a supplement resource. The other thing I often do is I have a patient who's on a drug. I can put in the drug, in this case, warfarin, and what will pop up is a list of all the herbs that might be associated with an interaction with warfarin. And they'll rate them as either major, that means there's a high likelihood of clinically significant interactions. We can go another level though. I can say, well, my patient's specifically on warfarin and they're going to take St. John's wort and then look at those specific interactions. The nice thing about this, I don't know if you can see it, but all of these interactions all have a little blue number. If we click on that, it'll take us back to the reference list. The reference list, most of the references are tagged back to PubMed, so we can actually go and read the original articles and make our own determination. So this becomes a very nice resource, which I can get a lot of information very quickly and oftentimes on the fly with a patient. And we'll talk about how we use this in other fashion in just a few minutes. Another website that's very interesting and sometimes helpful, this is consumerlab.com. And these guys also have a lot of great background information. If you want to go into a deep dive on vitamin K, they'll take you through sort of a similar monograph, a lot more written material, but a great place to say, I want to learn about vitamin K once and for all. Good place to do it. But where they kind of shine is their goal is to kind of look at the products. What's the quality of products? What's in the products and so forth. So here's a nice review they did on CBD products. And you can see if you say, well, how much CBD is in each product? Product A has a very high dose of CBD, product N, not so much. And if you can see the little red numbers, those are places where the THC content exceeded the legal limit for CBD. It's supposed to be under 0.3%. So very quickly, we can get an idea of where we might want to direct our patients. And then secondarily, they also do a nice graph of what is the cost. So product L for 10 milligrams of CBD is going to cost $2.67. And you can do the math. If you're taking 20 or 30 milligrams, you're going to break the bank very quickly for that patient. So again, a lot of nice information. And then the thing I use it most for, however, is their review of the different supplements. So here they take different supplements. They go through a very deep analysis. They look at the label. The label says X amount. They measure, they see if it has X amount. They look for contaminants, pesticides, insecticides. They also look for tablets if they're supposed to disintegrate in such a way so it gets into the system. They measure that. So as they go through this, they will come back and say, yes, this one is approved. It means it's met those quality criteria. They give you an idea of what it's going to cost to take a daily dose. So a lot of information in a very short time, and you can go through and find lots of products that are approved, and then occasionally you'll find ones that's not approved. So for example, this particular one only had about 83% of what they claimed on the label for the turmeric powder. So again, it's a quick way to find a lot of information. Now, it's not comprehensive. Not every supplement's here. So it's only part of the approach to answering that question of quality. And then the third database, which I've really enjoyed using, is something called Examine. Again, if you go to the top, you can see supplements. If we click on that, it'll actually give us supplements for sleep, supplements for muscle pain or whatever. Or we can just do like we did previously. We could put a search term right in the center there. Here's curcumin. And again, if we could go through the whole screen, there'd be about 15, 20 pages of information on curcumin, spaced out very nicely all the way through pharmacology, down to the interactions, down to the efficacy. So we can pick any of those points we're interested in, get a very deep dive. Where I find it oftentimes helpful with patients is go to what they call their human effect matrix. And there's a couple of nice things they've done. First, if we go down the left-hand column, you'll see the pyramids, a pyramid that has all 4 bars filled in. that is considered high evidence. That means there's probably meta-analyses, a number of different trials, all finding the same thing, all the way down to more or less case reports and so forth. So for number one, if we ask, does curcumin curcumin have any influence on triglycerides? The answer is, well, there's a lot of evidence. What it says is the magnitude of effect, minor. It could be notable or it can be strong. So minor means there's something there. And then they look at the consistency. Well, the 28 studies they reviewed, there was moderate consistency. Some said yes, some said no. Gives us a quick way to answer the question. What about antioxidant profile? Now we see, again, pretty good level of evidence, notable effect, and very high concordance amongst the 8 studies. Again, if you want, you can go click on the link. It'll take you back to the 8 studies. So again, a lot of information, a lot of it can be very deep, and that's the stuff I'm going to spend more time in on my own time. But if I need something on the fly, we've got 3 different ways of addressing a question that I think can help us help our patients make informed decisions. So then my goal is my patients is to have them have a plan. And I try and get them to think of themselves as scientists, right? If you're going to start a treatment, think of yourself as an experiment with an N of 1. And so, for example, my patient says, I've got really bad arthritis in my knees, and we've done good evaluations. We know that's what it is. They haven't been successful with something else. So then I ask them to kind of start with, where are you at today? Well, my knees hurt 8 out of 10. I'm stiff for 30 minutes in the morning. Great. Now we're going to start a high quality product. You're going to take it for 6 to 8 weeks, and then we're going to reassess. What is that level of pain? What's that level of stiffness? And if we don't see evidence of benefit, that means they're probably not going to respond. It's reasonable then to stop it, probably record that information so a year later we don't try it again and move on to something else. If they are getting benefit, it doesn't necessarily mean that I'm endorsing it or recommending it, but now we're going to partner with them to say, okay, you seem to be getting benefit. Let's track liver function test, blood count, make sure you're not having an idiosyncratic reaction or any other problems that we have. And then we can say that's something we can watch with you going forward. So that's kind of my approach with patients. As they have the interest, they're going to do it. I want to be there with them to help them make the informed decision. And then choosing a high quality product. We figured out several years ago when we started doing dietary supplement research here in Rochester that we wanted to find companies that, of course, followed good manufacturing practices. The ISO standards for process of how you manufacture are very important. There's specific certification in the European Union, and there's really stringent or more stringent certification in Australia. So companies that meet all of these or most of them, we start to see they've put in the effort to get those certifications. They've got the quality. We look for companies that are either doing research, have supported research, or at least are pulling together the research in a way that says, this is why we think our product can be helpful. And I also like to find companies that do independent adverse event reporting. So every company is required to, when an adverse event happens to one of their products, they need to record that. It's fairly easy to bring that in under the covers and maybe not do as much with it as we should. If we have an independent company doing that for the manufacturer, we know we're going to get much more transparency. And that also allows better reaction if we're seeing a signal where there are increasing adverse events. Did something change in the manufacturing process? Is there something changing about how patients are using it? So I think that's how we are able to be fairly confident that we're staying ahead of the curve in terms of keeping our patients safe and making sure they get the best benefit they can. There's a number of these third-party verification systems. USP stands for United States Pharmacopoeia. We talked about Consumer Lab. All of these have different approaches. All of these will give a label to a supplement that has met their criteria. So it's verified to have what they say it has. These are great when we have them, but the penetration into the market, there's far more products out there without these and with them. So they're helpful when we have them, but their absence doesn't mean the product's not good. We still have to go back and do our homework. All right, so take home points. How do I put all this together? Number one, supplements are popular. They're going to be part of what we do in HIA. They're going to be part of what we do in our individual practices. And they're probably what are going to be part of what we do for individual health, at least 80% of it, if the statistics are correct. So if they're going to be popular, how do we respond to this? Do we jump on the bandwagon? Do we throw rocks? No, we're going to try and find that middle ground and help our patients make informed decisions. Look at dietary supplements. They can be a door opener for wellness, right? Remember the slide? Dietary supplement users tend to have many other good benefits. I look at this and my 30 years ago, self would have said, oh my gosh, how can you waste so much money? This is really stupid. And now I look at this and say, wow, you are really trying to optimize your health. Look at all the investment you're doing here. As you do this, have you built the foundation? Are you doing the nutrition exercise? And that at least allows them to kind of understand that we're not going to throw rocks. And then as we get through that, I say, well, now you recognize that you're getting vitamin A in 16 of these products. Maybe we could, and so we often find a way, probably not to get rid of 60, but maybe we can get down to 10 or 15 and then work our way down further and further. So those who have a belief system that says this is how I do it, saying don't do any of it, probably not going to be effective because they'll just not tell us the next time. So how do we use this as a door opener and help the patient more informed decisions? Risks and benefits, hopefully we don't have any doubt about that. The risks are there. Heart transplant rejection, that'd be a terrible thing to have happen because we didn't take our time to look at the interaction between St. John's wort and cyclosporin. On the other hand, I sure don't want to say no herbs, no supplements, and let somebody with vitamin B12 deficiency go on to permanent neurologic damage. So clinicians, I think our job, again, let's find a good e-resource. We went through 3 very quickly. There's a lot of other cool things they do, a lot of other ways they can be used. These are not necessarily the best or the only ones out there. We may, in the discussion, find other ones. And I think that may be one of the things we do as we get more comfortable with how our patients are using supplements within the Atria milieu. Maybe we come up with other databases that we want to use in place of these or in addition to these. So this is just a starting point to get the dialogue going. The other thing I think is really key is there's no way any of us can know 60 different supplements at any level that's going to be useful on the fly, but most of us have a focus. So for example, I see a lot of older folks. So of course they have a lot of osteoarthritis, insomnia. So I don't necessarily use these, but I know many of my patients are going to show up. They're going to be on glucosamine chondroitin. They're going to be taking SAMI. They're going to be using curcumin. And what I need to know, because I see them every day, is do I have to worry about this? Are there drug-herb interactions? What's the likelihood they're getting a benefit? So again, if you were in pediatrics, you probably don't need to learn about glucosamine since degenerative arthritis should be pretty rare in that population. But in each area, wherever you practice or wherever your focus is, there will be some unique supplements, which I think would behoove each of us to get that skill set for at least the top 3, 4, or 5 that we're all going to see on a regular basis. Finally, find the high quality manufacturers. This has been our rubric at Mayo, and we've been doing research. And now when I look for recommendations from my patients, I always try and go through this with them. I think we can find other ways to do this as a group, but certainly there are ways to find the really good manufacturers who I think follow manufacturing practices very close to what the drug manufacturers do and stay away from the fly-by-night outfits out there. And then the idea, how do we partner strategically? Again, I hope you're getting the flavor. There's a middle ground. We're not endorsing. We're not throwing out the baby with the bathwater. We're going to put the supplements in their proper perspective. They are not the driver of health, lifestyle. But when we need them, because we're deficient, because we have a depletion, because we have a symptom that we cannot control successfully, completely with conventional approaches, we're going to explore those and bring them in under the tent in a scientifically evidence-based fashion. So I'll leave you with a quote from one of our founders. This is Dr. William Mayo. You may know the primary value at Mayo is the needs of the patient come first. That's attributed to this quote from a speech he was giving at a medical school. And we hear the first part quite often, the best interest of the patient, only interest to be considered. We often don't hear the second part, and that is in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. And I think that's brilliant. I probably wasn't thinking of acupuncturists at that time, but think about our ability now to tap into an evidence-based approach, these other sources of potential therapeutic benefit, not only supplements, but mind, body, massage, animal-assisted therapy. And I think if we can bring those in together, we're going to have a much bigger toolkit. And I think we have a much better chance of really optimizing health and hitting that mission of Atria that I shared at the beginning.
If not, Brent, we really appreciate your time today. That was fantastic presentation, very useful, very practical, and we're going to be calling upon you, as you know, to help us as we roll this institute out. So thanks again, Brent. Have a great weekend.